My name is Dr. Pearce, and I work both for the Royal College of Anaesthetists in the United Kingdom as the Environmental and Sustainability Advisor, as well as being a consultant anaesthetist at the University Hospital in Southampton. And the talk I'm going to give is that of reducing the carbon footprint of anaesthetic gases. Looking at my overview, being mindful that this presentation may be for those who are not necessarily anaesthetists, I'm going to talk about the anaesthesia process. I'll move on then to talk about some atmospheric science, and then I will review the agents used for inhalational anaesthesia. I'll then progress to discuss some tools that might help reduce the CO2e of anaesthesia. But then, last of all, I'm going to mention of some administrative components. Now let's talk about the overview of anaesthesia. Anaesthesia, as we perhaps have experienced from our own lives, may be local or it may be general. A local anaesthetic, where the local anaesthesia is given into the tissues that are being operated upon, for example, the removal of a small cyst, or indeed into part of the body controlled by taking the nerves, and so that regional parts of the body can remain anaesthetized. Now, general anaesthesia, on the other hand, might take the form of intravenous agents, what we call, not unusually, TIVA, which stands for total intravenous anesthesia, or indeed it can be a mixture of that and inhalational anesthesia. And it is this area of inhalational anesthesia that I tend to concentrate most on. Let's look at some practical components of anesthesia. Every anesthesia requires some form of drugs. I've illustrated some here, and in this particular setting, these are prepared for a patient about to undergo cardiac surgery. And to those drugs, we're also going to give in anesthesia some inhalational anesthetic agents. And they are delivered from devices such as these. These are vaporizers. The yellow color-coded one is that which we would use to contain a drug called sevoflurane, and the purple-colored one here would be the one that contains the drug isoflurane. And these agents are then delivered to our patients whilst they are anesthetized within the breathing mixture that they receive to their lungs. So let's think about some of those breathing components. And the picture here I want to illustrate to you is some of the plastic disposable anesthesia airway equipment that we need to connect the anesthesia machines directly to the patients. But we must also be mindful that our drugs need to be given by the intravenous route, and so connections to the veins are important. And fluids are also vital to help maintain homeostasis. And in my picture in the middle here, I show one or two other components that are used in the earlier phases of anesthesia to establish the connection of the airway equipment to the patient. What happens to all these components? Well, the disposable components are often combusted as part of the combustion of clinical waste. Now, when we combust any form of plastic, polyvinyl chloride tends to be the most commonly used plastic. Combustion of 1 kilogram of polyvinyl chloride will produce an additional 3 kilograms of CO2. What about the intravenous drugs? Well, fortunately, the body's metabolism, either in the liver or in other sites, will metabolize the drugs, and they are often excreted by various routes, not unusually by the kidneys. What about unused drugs that are not given to the patients? Drugs left in these syringes at the end of anesthesia. Well, those are returned to the combustion bin too and combusted at high temperature. Packaging. All of our equipment comes in one form of packaging or another, and we may be working in an environment where some of that can be recycled. If not, that too is often combusted, but depending on the quality of the type of paper, the combustion of 1 kilogram of paper will yield somewhere between 2.1 and 2.6 kilograms of CO2. What about the inhalational agents? Well, for the most part, these, once breathed in by a patient, are then breathed out. And when they're breathed out, they are then disgorged to the atmosphere unchanged. The slight exception to that is that of sevoflurane, of which about 4% of that agent will be metabolized by the patient that receives it. Let us look now at those inhalational anesthetic agents. They are all relatively small carbon molecules on a backbone of carbon attached via an oxygen link to another carbon group, and that makes them substituted ethers, and the substitution is largely with fluorine. Now, the characteristics of each of those agents varies. Let's take, for example, sevoflurane. The global warming potential of sevoflurane is 130 times that of carbon dioxide. What that means practically is that if we were to use an entire bottle of sevoflurane as part of our anesthesia process, and that bottle would contain 250 mils of the inhalational agent as a liquid. When vaporized, that has the same global warming effect as 44 kilograms of carbon dioxide. And we get to desflurane. It has a global warming potential of 2,540, which means that a bottle of desflurane is a little smaller in its volume than that of sevoflurane. A bottle of desflurane, when entirely vaporized, has the same global warming effect as 886 kilograms of CO2. Not unusually, we use nitrous oxide in an anesthetic setting, and a small cylinder of nitrous oxide, size E cylinder, weighs about 3.5 kilograms, and once emptied, that cylinder would have the same effect as over a ton of CO2. Now, in my cartoon here, I've illustrated rather simply a little bit of atmospheric chemistry. The sun, radiating as it does from the surface of the sun at a temperature of about 6,000 Celsius, emits radiation largely in the visible spectrum. This is transmitted across the 93 million miles to Earth, where it warms the atmosphere, and some of that gets transmitted to the Earth. But the Earth, like any body, also radiates radiation, but because of the temperature, the peak radiation frequency, or I should say wavelength, is around about 10 micrometers. And this is the peak radiation and is known as the atmospheric window. Now, throughout time, various atmospheric constituents have been present within the atmosphere, and these have the effect of absorbing some of the outgoing radiation. I've illustrated informally where they sit, and you'll see some of those, like methane, nitrous oxide, carbon dioxide, and water vapor. And they are responsible for keeping the planet a little warmer than it would otherwise be. Now, agents that are disgorged into the atmosphere, such as the inhalational agents I've mentioned, sevoflurane, isoflurane, and desflurane, as well as other chemicals in the atmosphere, such as hydrofluorocarbons, chlorofluorocarbons, and hydrochlorofluorocarbons, the net result of that is that although they are present in very small quantities, they constitute a relatively large amount of additional radiative forcing. Indeed, the yellow constituents here, the sevoflurane and so on, contribute about 10% of that additional radiative forcing, whereas CO2, 65%, methane, 18%, and nitrous oxide, 6.4%. And the concentration of the inhalation anesthetic agents has indeed risen over time. This is the work published by Vollmer in 2015. And what we see from this is that concentrations of drugs like sevoflurane have risen over time. That of isoflurane, again, has risen over time, but plateaued perhaps to some extent. But the concentration of desflurane is still continuing to rise as its popularity as an anesthetic agent is increasing. That is one factor that explains why the concentration is rising. The other factor is related, of course, to its global warming potential, and that is that the lifetime of that agent is greater than some of the others. Now, we mustn't forget, of course, that the atmospheric constituents of CO2, methane, nitrous oxide, and other man-made chemicals are also changing inside the atmosphere. Returning to the lifetime of the inhalational anesthetic agents, if one notes those agents with the lowest global warming potential, such as sevoflurane, has a very short atmospheric lifetime of only 1.1 years, whereas desflurane, on the other hand, with a high global warming potential, has an atmospheric lifetime in the troposphere of 14 years, and that explains the difference between the global warming potentials. So, what about the peculiar aspects of inhalational anesthesia? We've seen that they are volatile, substituted ethers, largely substituted with fluorine, and at room temperature they exist as liquids. They're vaporized and added to the anesthesia breathing circuit in concentrations that vary from agent to agent, but generally over the range of 1 to 8%. The carrier gas, that is to say the larger volume of gas that is delivered to a patient, is generally an oxygen-air mix, or at times an oxygen-nitrous oxide mix. Now, you might think that the depth of anesthesia depends on how much agent you're giving. Well, rather, it depends on the amount that one is exhaling, and I don't think this presentation has time enough to describe the reasons why. Once those agents are exhaled, they are recycled, sometimes delivered back to the patient again. But once at the end of anesthesia, they are breathed out and they go straight to the atmosphere. Now, most of the CO2 procurement of inhalational anesthetics is not in the manufacturing, but rather more in the disposal of that agent. The picture on this side shows an anesthetic machine, the type of thing that will be able to be connected to a patient and deliver the inhalational agents and the anesthesia. If we were to turn that around, we would see on the back the connections of oxygen, of nitrous oxide, and of air to that anesthetic machine. And as I've already illustrated, we have vaporizers on that anesthetic machine in order to be able to keep the patient asleep. Now, the monitoring that we're using has been tailored and developed in order to help us with that complexity. And on my slide here, I'm showing a photograph taken from the screenshot of the patient under anesthesia. And you'll see that we're measuring at this point here the end tidal concentration, in this particular instance, of isoflurane. The patient has received, in the previous minute, 10 breaths from the anesthesia machine, each one of which was of 500 mils. But notice that the total gas that's being delivered to the anesthesia machine is a lot less than that, because so much of it is going to be recycled. Indeed, the fresh gas flow is 1 litre, of which 200 mils is oxygen and 800 mils is air, and the concentration of oxygen in that gas mixture is 35%. So there's a scope for choice in anesthesia. One might choose general anesthesia or regional anesthesia. If choosing general anesthesia, either an oxygen-air mix or an oxygen-nitrous oxide mix. And of the inhalational agents, we can choose the type, we can choose the fresh gas flow, and very often we would want to use low-flow anesthesia, and we can choose the added intravenous agents or sedatives or analgesics that are required to give a balanced anesthetic. In 2012, the Sustainable Development Unit in the United Kingdom explored specifically that of anesthesia gases, by which they referred to nitrous oxide, sevoflurane, isoflurane, and desflurane, and concluded that overall, inside the carbon footprint for the NHS in England, they constituted around about 0.6 million tonnes of CO2 equivalent. And looking specifically, the conclusion was that this represented a relatively large proportion of the carbon footprint of the acute, that is to say, the hospital sector, amounting to about 5% of the organizational footprint. And their conclusions are as valid then as they are today, that measuring, monitoring and reporting carbon dioxide equivalent emissions from inhaled anesthetics is crucial if we wish to reduce admissions. The EU and the European Commission have got stringent regulations in place regarding the reprocessing of the cylinders which contain our medical gases. And I'll use this and describe it in exact terms, that cylinders that have been returned for refilling should be prepared with care to make sure that they minimize the risk of contamination. And these procedures specifically should include evacuation and or purging operations, and these should be validated. Well, the significance of this is that if one knows and has record of the cylinder numbers that are returned for refilling, then by definition we can conclude exactly how much of each medical gas has been used in that cycle from manufacture to patient cylinder return. Indeed, we've done this with nitrous oxide cylinders by obtaining cylinder return data and making some straightforward calculations based on the universal gas equation. One can actually calculate the CO2 equivalence of the vapor that we're using, that's to say nitrous oxide in this instance. But we also use nitrous oxide in oxygen and nitrous oxide mixtures that, for example, would be used by ladies in labour and for other short-term pain-relieving procedures. So that's how we measure the CO2 of anaesthetics of nitrous oxide. But talking about the inhalational agents, the job is much simpler. We just need to know the number of bottles, the volume of each bottle, the density of each liquid, and the global warming potential. I put this together as an anaesthetic agent CO2e calculator, and it's available from the SDU website. I've illustrated 1 year's use at the University Hospital in Southampton. We can see the number of tons of CO2 equivalent related to nitrous oxide in anaesthetic terms, the Entonox in the maternity unit, and just tucked up here you can see the effect of the inhalational agents. For example, 190 tons of CO2 equivalent from the use of isoflurane. I've plotted those trends over time for our hospital's use from the years 2008 to 2015. And you'll notice that the anaesthetic use of nitrous oxide, as evidenced by the blue bars, has fallen over time, but stabilized since the year 2012. The amount of nitrous oxide used in the maternity setting has remained fairly constant, despite, I am told, an increase in the number of births. But as you can see, the overall effect is around about the equivalent of 3,000 tons of CO2 from one hospital's anaesthetic agents. And the trends that I've just described in our hospital seem to have been replicated throughout the country. And this is for one medical gas supplier's sales of nitrous oxide. And you'll see that similarly, the trend has been to fall since about 2008-2009, but has remained fairly constant in the years since. So what accounts for this change in the CO2e and the reduction in the use of nitrous oxide? Well, it's very hard to say. One option could be that we're using less general anaesthesia and more regional anaesthesia. It may be that we're moving away from what would be considered to be a nitrous oxide oxygen mix for our carrier gas to an oxygen enriched air for the carrier gas. It may be that we're being generally leaner, using lower fresh gas flow rates, and so a greater amount of intraoperative recycling of those inhalational agents. It's hard to say. And those annual data are a way of plotting trends. Sadly, though, of course, they're historical. They're not contemporaneous. And I'm not certain how well the use of that data will change individual anaesthetists' behaviour. What I've moved on to do is to devise a real-time CO2e calculator. We all in anaesthesia practice know our total fresh gas flow in litres per minute, and we know the vaporizer setting. We have to make one or two assumptions about the behavior of each of the inhalational agents, but we know the temperature, and we can derive from those the mass of each agent used. And then we can even go one step further and actually calculate the cost of that anaesthetic. I've chosen two examples. My first example is that of a patient receiving a fresh gas flow of half a litre of oxygen and half a litre of air per minute. That's the fresh gas flow. And in my first example here, I'm set the vaporizer, in this case isoflurane, to 1.9%. This has the CO2 equivalence of around about 4 kilograms of CO2 per hour. It's a very cheap drug, costing no more than 24 pence per hour. But to try and put some realistic interpretation on that, I have, in this example, expressed that as a distance travelled by a relatively small car. Now contrast that with desflurane. You'll notice that desflurane has to be given in a higher concentration. In this case, we're setting the vaporizer at 5. Notice here the CO2 equivalence, and this, of course, reflects the much higher global warming potential. The cost, very much more expensive than isoflurane, and to put it in context, the equivalent of driving a relatively small car 328 kilometers per hour of anaesthesia. Let me just change the gases mixture a little bit, and let's add in nitrous oxide then. So we have a 50-50 mixture of oxygen and nitrous oxide. And the isoflurane remained much the same, but now see how that value of the CO2e has increased to 21 kilograms of CO2 equivalent per hour. It remains still very inexpensive. The effect, however, of adding nitrous oxide to an agent such as desflurane isn't that great because desflurane's CO2e is so high. If I was to look at my own practice over the last 25 or 30 years and contrast my anaesthetics that I used to give, when I would use oxygen, nitrous oxide in a relatively high flows, I could model an example to show that I would perhaps have the equivalent of nearly 140 kilograms of CO2 equivalent per hour of my anaesthetic that I would have given in the year 1985. Contrast that now with my choice of anaesthesia. Nowadays, I'm going to use a circle system. I'm going to recycle those agents. I'm going to use low flows, and I've reduced my CO2 equivalents down to 3.5 kilograms from the very high 140. So my own practice has changed over time, but that's reflecting, of course, change in the technology that we've also been able to have at our disposal. Jody Sherman in the United States has explored this a little further and made comparisons between the carbon footprint of an anaesthetic with either an intravenous or an inhalational basis. You'll see it stands for peripheral nerve block plus general anaesthesia, and in this relatively small number of patients, 12 in this example, the CO2e for each anaesthetic was about 50 kilograms, as it was for a general anaesthetic on its own. But if, on the other hand, the general anaesthesia had been given by total intravenous anaesthesia, that value fell to somewhere around 5. And this is just a reflection of the significant global warming effects of inhalational anaesthetics. Now, that's only part of the picture that we're faced with in anaesthesia. We've got to get patients into hospitals. We've got to get staff into hospitals. We've got to think about the devices that we use. Should they be single-use or should they be reusable? What about the source of our electricity? Does it come from a renewable source or does it come from the combustion of coal? We have, of course, to keep the patients warm in the large operating rooms in which we work, and we have to give some thought to how we recycle our paper and any of our other equipment that might be used by another patient. So in my slide here, what I've done is I've put as much science as I could to behind the process of changing one's behaviour. In my first bar, which I've labelled current practice, I have looked at our recycling and considered it to be less than optimal and ascribed to it a CO2e. My yellow bar beneath that represents the anaesthetic gas scavenging system, which in a less than ideal world I've left on all day and all night. It is the suction apparatus that removes waste anaesthetic agents from the atmosphere in theatre to the roof of the hospital. In the grey section here, I've calculated the carbon dioxide equivalence of running the air handling units that supply our theatres with so many air changes per hour, and applying a value of around about 700 grams per pound spent as representing the CO2e of our disposals, I've got a figure here for the CO2e of drugs, of not so many drugs, but equipment and our drugs that we use. My purple section here represents isoflurane, that is to say the CO2e of a day's anaesthetic using isoflurane, and the deep blue, that of using nitrous oxide. Now, if that were my anaesthetic practice, what could I potentially reduce a day's anaesthetic to? Well, this is the figures here. The orange section, I've managed to recycle a little bit more. I've turned off the anaesthetic scavenging at out of hours, and I've insisted that the estates department put our air handling units on setback out of hours and run at a low level of air conditioning, particularly when those rooms are not used at night time. The drugs and disposables that we're going to use remain much the same. But the biggest difference of all is that there is no blue. I've moved to an oxygen-air mix and removed nitrous oxide completely from the mixture. If, on the other hand, I was thinking that rather than driving the car, I would choose active transport, a very small additional benefit could be gained by switching from the car to my bicycle. We can only do what we've done with the help of the manufacturers, and this particular anaesthetic machine manufactured by GE has the capacity not to dial up and set the concentration that you want on the inspired mixture, but as I've alluded to already, this particular machine will dial up a concentration to achieve a specific end-tidal concentration. Within anaesthesia structure in the United Kingdom, the Royal College of Anaesthetists has been behind a lot of the initiatives, and I list one or two of them here, all of which would have an impact, or potentially could have an impact, on our practice and our green credentials. For every specialty, there are guidelines for the provision of anaesthesia services, and within that document are guidelines for how green our anaesthetics could be. Initiatives such as Getting It Right First Time, an NHS initiative, really should contain within that guidelines for greener and leaner anaesthesia. And this particular document Protecting Resources and Promoting Value was produced from the Academy of Medical Royal Colleges in 2014 and contains some very useful and very easily applicable advice. Let's think about those guidelines for the provision of anaesthesia, and particularly with reference to a greener environment. The advice suggests that we work with the states to minimize energy use. Anaesthesia should be given using low-flow anaesthesia with specific reference to avoiding nitrous oxide within reason, and if desflurane is the agent of choice, then it should be used under low-flow conditions as a matter of course. Choosing wisely looks at other processes, day surgery particularly, the requirements for routine preoperative tests, and strategies to improve the fitness of the patients who are going to undergo surgery and anaesthesia. So in summary, the overall impact of anaesthesia is small on the global scale compared with other greenhouse gases. However, the proportion of CO2e in healthcare delivery attributable to anaesthesia is significant, and there is scope for informed choice of practice. We could reduce or eliminate the use of nitrous oxide, and if we did, then that would be the single largest contribution one could make to greening one's anaesthetic. The impact calculator that's available free as a download to either iOS operating systems or to Android systems might be able to help with those choices. But we mustn't forget that we need systems and processes in place to encourage greener and leaner behaviours. And my last slide here just describes those two measurement tools and where one might be able to obtain them.